Physiology and Developmental Neuroanatomy for the Newborn Brain Society, and I remain most appreciative of this opportunity to present my experience to the members of the NVS, and I especially am grateful to Dr. Khurshid Muhammad for arranging this for me and allowing me to make this presentation and the others. So the topic I would like to present today is the development of fissures and sulci in the human fetal brain and some of the disorders that we see that are related to abnormal development of these structures and why these structures occur at all. And so the learning objectives are, first of all, to know what the difference is between a fissure and a sulcus, and then to understand one of the principal fissures, which is a telencephalic flexure that forms the lateral cerebral fissure, which is called the Sylvian fissure after the operculum closes, and to appreciate also major malformations of the nervous system that may include defective development of the telencephalic flexure or abnormal gyration and sulcation. And also to appreciate how fetal hydrocephalus may or may not affect the Sylvian fissure. No conflicts. And to begin with, there are a number of developmental processes that occur in development of the brain. And these often are listed numerically, but they really shouldn't be because they are processes which occur simultaneously in large part. There's a few that occur only early, such as gastrulation, and some that occur late in development, such as myelination. But most of the processes are occurring at the same time. And for that reason, I've demarcated them with bullets rather than numbers. And the one we're going to talk about today is flexures, fissures, and crenations, and other convolutions and gyri in the developing brain. So, what are the differences between a fissure and a sulcus? Both fissures and sulci are grooves in the brain, and they are formed by mechanical forces that occur with brain growth. But a flexure occurs predominantly from external forces as the cranium is developing and as the ventricular system is developing. And the ventricular system is actually an external force, because even though it's enclosed by the brain during development, it really remains outside the brain and should be considered in the same way as forces external to the brain. Sulci, by contrast, form predominantly from internal forces because of increasing tissue volume resulting from the growth of cells and of neuropil. In general, fissures form earlier than do sulci during the first half of gestation, and sulci occur later. And fissures also are usually deeper than sulci and often separate different lobes of the cerebral cortex. So here are the principal fissures of both the hindbrain and the forebrain. We're going to talk mainly about the forebrain fissures today. And there also are more than 30 sulci in the mature cerebral cortex. It's important to recognize that with gastrulation, that there are axes and gradients of the entire fetal body, or embryonic body, I should say, at that age, and also of the neural tube. So that at the time of gastrulation, we have the establishment of the three principal axes, the longitudinal, vertical, and horizontal. And there are gradients of genetic expression which are seen with each of these axes And there are two gradients in opposite directions. In the longitudinal axis, for example, you have a rostrocaudal gradient, but you also have a caudorostral gradient that may be affected and affect only structures at the posterior end of the neural tube rather than at the rostral end of it. And you have similarly dorsal and ventral gradients of the vertical axis, and you have mediolateral and lateromedial gradients of the horizontal axis. And you can even see this early with Henson's node, or the primitive node, in the early embryo at the primitive streak stage, because as the primitive streak is forming, you can see that there, with this particular marker for the gene C0, and this is a chick embryo, you can see that you see it expressed first at the left, labeled B, in the primitive node, and then as the chick embryo is progressing in time in development, you can see it extending, but with a decreasing intensity, and still further in D, you can see that it's extending even further, and there's a gradient of expression which is stronger at the end of the node than it is distally. And we can see this also in developing brain. For example, this is the EMX2 gene in the mouse, and in this sagittal view, you can see that it's strongly expressed in the medial portion, and as you go around the ventricle and where the corpus callosum is forming, you can see that it decreases in intensity and becomes more diminished because of this gradient. And when some of the flexures start to develop, for example, the cervical flexure and the pontine flexure, as you see in this cartoon, you can see that the gradient follows the axis of the embryo rather than being altered by the flexion that you have in the mesencephalic area, and also that's the pontine flexure, and also the flexion that occurs in the opposite direction, rostral to the spinal cord forming, and that's the cervical flexure. Now, when we look at the development of the telencephalic hemispheres, we start out at 3.5 weeks gestation with 3 vesicles, or sort of enlargements of the neural tube. But the ventricle that's inside the neural tube is continuous in all 3. And as you progress another week to 4.5 weeks, you start to see development of the interhemispheric fissure, which is the first fissure that divides the primitive prosencephalon into 2 portions, which become the telencephalic hemispheres. If you look at a lateral view of the primitive telencephalic hemisphere, you can see that the posterior pole of the primitive telencephalon will become, with the ventral bending that forms the telencephalic flexure, will become the temporal pole of the hemisphere, not the occipital pole. It looks like it would be occipital at the beginning, but with the flexion, you can see that painted in green that it becomes the temporal pole. The occipital lobe actually starts out in the dorsal surface of the primitive telencephalon, and as the telencephalon undergoes flexion with telencephalic flexure, it's pulled posteriorly so that it becomes the occipital pole in the more mature brain. And the more ventral part of the primitive telencephalon becomes folded inward as the insula as the um, operculum is forming and will form the sylvian fissure, eventually outlined in red. One other feature that you should notice in this cartoon is that the occipital horn of the ventricle is the last part of the lateral ventricle to form, and you'll see why that's important later. The temporal horn forms by the bending of the ventricle along with the telencephalon, but the occipital horn forms only after the blue portion, which represents the occipital pole or striate cortex of visual area, is already the posterior pole, and it forms last of all. So let's look at some real brains to see how they look. Here you have a fetal brain of a 9-week fetus, and you can see on the ventral surface especially, you can see the beginning bending of the telencephalic flexure. And the pole, the posterior part of that telencephalic flexure is what will become the temporal pole. At 14 weeks, you can see that you already are starting to form an operculum in this lateral view, but it's extremely shallow, almost at the same level as the rest of the brain, and is not really internalized just yet. The yellow color is artifactual. That's because of the fixation in Bowen solution, which is picric acid solution that turns the tissue yellow, so don't pay attention to the color. And here you see an 18-week fetus with further development of the telencephalic flexure as it's bending around. And you can see deepening of the insula as that happens. And by mid gestation, 19 and a half weeks here, you can see that it becomes quite a bit deeper. This brain was not fixed in Bowen solution, so this is how it really looks. And here's a 22-week fetus showing, again, deepening of the operculum. And here is an infant that's essentially a almost term infant, well, 32 weeks conceptional age. He's actually 9 days old, but it was born very prematurely. And you can see that the telencephalic flexure has formed well. The temporal lobe is well formed, and you can see it, the temporal tip here that used to be in the most posterior part of the hemisphere. And you can see that the operculum is still quite open at this age at 32 and a half weeks. And you can see the easily visualize the insula, which you see in the depth of the operculum. And by term, the operculum is now closed. And you can see that when it is closed, it's then properly called a sylvian fissure. It isn't really a sylvian fissure until the operculum closes. You'll notice that the superior, for later reference, the superior temporal gyrus here is well formed, middle inferior temporal gyri. And even going back in earlier brains, you can see the superior temporal gyrus, not this early, but this one, you can see it well formed, and we'll see why that might be important later. The calcarine fissure develops on the medial side of the occipital lobe only after the telencephalic flexure is initiated and the occipital pole is formed, and that occurs at about 10 to 12 weeks gestation. And it's closely related to the bending of the forebrain with the telencephalic flexure, and intimately related to the growth of the calcarine fissure is the growth of the occipital horn, the most recent part of the lateral ventricle, as a new recess out of the lateral ventricle. And these all form before axons of the optic radiations or the geniculocalcarine tract are completely projected to the occipital lobe. So it's before you have the thalamocortical projection to the visual area. It's important also to recognize that because it's the newest part of the lateral ventricles, that the occipital horn is the most variable part of the ventricular system, really, as normal variants of otherwise normal brains. And so only in about a quarter of us normal subjects, um, as you see in the left view, are the occipital horns completely symmetrical, and as you see in these axial T2 images from MRI. In about half of normal subjects, the occipital horns are asymmetrical. You can see that it extends further posteriorly and is larger here on the left than it is on the right in the middle of the view. And in about a quarter of us, the occipital horn on one side is either very rudimentary in development or doesn't form at all. And that is a normal variant. That is not pathological and doesn't impair vision or do any clinical impairments at all. It's just a normal variant of normal that you would see in controlled MRIs or neuropathologically um, in the brain. Here you see it in coronal section. Again, the asymmetrical, this is the asymmetrical occipital horn with just a bit of it showing in the more rostral portion, and in the more caudal portion, it's not seen at all on the right side. And in sagittal view, you can also see the difference in the occipital on one side and the other. If you look at cut surface of fetal brains, however, this is a 22-week fetus, mid-gestational fetus, and here you have asymmetry of the occipital horns. The larger one that you see on the right side of the screen is normal for this age. The one that you see that's smaller on the left side is too small, or it's asymmetrical at least, and smaller. There's a little bit of plasma in the ventricle, but that's of no consequence. Don't worry about that. But the important thing to look at here also is that the depth of the developing um, calcarine fissure. Here on the normal side, you can see that it's deepening. On the side with the smaller ventricle, the calcarine fissure is forming, but it's much more shallow, especially compared to the other side. This is the same brain. And so that's also an important feature to be aware of when you're interpreting imaging. The parieto-occipital fissure is the fissure that separates the parietal and occipital lobes. And it's evident on the medial and lateral sides of the hemispheres, but more on the medial side. It starts to develop at about 16 weeks gestation, and it's the last fissure to actually form in the forebrain. It can be demonstrated prenatally by fetal ultrasound or by fetal MRI. And sometimes in the literature, it's been called a sulcus, parieto-occipital sulcus, but it isn't really a sulcus, it's really a fissure. And we even wrote a paper about that a couple of years ago to give the reasons why it's important that that it is a fissure. If you look at the lateral surface of the hemispheres of these control brains, where number 4 that you can see here in the upper middle panel, you can see that there is on the lateral surface that there is a groove formed, and that is the parieto-occipital fissure it's forming. And it becomes more evident as progression occurs. Here it is. You see here, at 32 weeks, as progression occurs in age and in development of the brain. If you look at the medial surface of the hemispheres, you can see where the asterisk is pointing to where the parieto-occipital fissure is, and you can see it as a much deeper groove on the medial side of the hemisphere, separating the parietal and occipital lobes. So that's another fissure that you should be aware of. And I might mention also, posterior part of the hemisphere, that the parietal bone, most of the calvarium is formed from neural crest tissue and therefore is membranous bone. But the posterior part of the parietal bone and the occipital bone are endochondral bone formation, and they come from a different source, embryologically from the paraxial mesoderm. And this is the reason that the lambdoidal suture in the skull is a serrated, irregular suture, where in comparison with the smooth suture that you see is the coronal suture and the sagittal suture and metopic sutures, which are all from neural crest. Now, looking at the parieto-occipital fissure in axial views of ultrasound, at 18 weeks, you can see it just beginning. Actually, you can see it at 16 weeks, but it just looks like a little dot on the medial side of the hemispheres in the posterior region. And as you follow it developing, you can see that it becomes much more evident. You can see by the arrows here in B where it's forming, and here you see it even at 23 weeks. It's forming. OH means occipital horn. This is choroid plexus. This is the cavum septi pellucidum. It's the anterior part of the hemisphere of the brain. Frontal FH is frontal horn. Okay, and here we see it progressing further, and by 34 weeks, it's quite evident that the parieto-occipital fissure is very evident in cranial ultrasounds. And if you look at it in a parasagittal view, you can see the double arrows here, that the occipital lobe is at the bottom, and here's the nose, here's the frontal lobes here in this fetus, and you can see the parieto-occipital fissure on the medial side of the hemisphere, which you can see well in this view. So the sulci of the brain begin forming during the second half of gestation, and they start at around 22 weeks gestation normally. Occasionally, you can see precocious development at earlier ages. I'm going to show you an example of that. And they result, as I mentioned earlier, mainly from internal mechanical forces, from growth of cells and neuropil, but are genetically programmed in a precise anatomical sequence and morphology that you can always identify the gyri and the sulci. And there is an evolutionary need for convolutions to occur in the cerebral cortex, because the cerebral cortex is a laminated structure. And with the large number of cells that it contains by term, the growth of the brain, if you had a smooth brain and you didn't have the development of the sulci, the brain would be so large that it would be unsafe for delivery for either the infant or for the mother. And so, or else the alternative would be that the infant would have to be delivered quite prematurely. And we all know about what some of the complications of prematurity are. So that this is an evolutionary need for convolutions so that you can increase the surface area without a concomitant increase in volume of the brain. And there are some species of mammals, such as rodents and rabbits, lagomorphs, that have smooth brains, but they have a much reduced number of total neurons and glial cells in the cortex, and they really don't have the same need for increasing the surface area. And non-mammalian vertebrates such as birds, reptiles, and amphibians, fishes, well, fishes have a special kind of folding of the brain. These animals don't have convolutions of the forebrain either, but their organization of the forebrain is very different from the mammalian brain. And therefore, they have more of a nuclear rather than a laminar pattern, and the growth pattern is different. Now, here's an example of precocious formation in a 16-week fetus. Here you can see coronal sections here, the lateral ventricles. These are the frontal horns. The corpus callosum is artificially torn here. It should be continuous in the midline. And here's the internal capsule, white, caudate nucleus, and the putamen on the other side of the internal capsule. And you can see in this brain that you are starting to have some incipient sulci that are forming. These are not fissures, these are sulci. This is the interhemispheric fissure here, which looks wider than it should be because the brain is torn in the midline. It should be closer together. But these are early sulci, and if you look at them histologically, you can see the early incipient formation of a sulcus here and gyri. And on the right, you see a Vimentin stain, which is immunoreactive to the radioglial fibers, and you can see them ascending here through the white matter and going into the cortex and actually extending to the pial surface. And they go when they reach the sulcus, they sort of divide around the sulcus. Here's another example of another sulcus, and you can see that these radioglial fibers in the middle, Vimentin immunoreactivity, are going around the sulcus. Synaptophysin shows that there is only a little bit of synapse formation in the molecular zone of the cortex, but this also is a little bit precocious. And how do we know that those weren't artificial artifacts, fixation or something that caused those sulci to form? Well, the reason is that we see precocious development of synaptophysin as well in that area, and that wouldn't be affected by any artificial shrinkage or handling of the brain that would cause artifactual folding. Cerebellar folia are similar to cerebral gyri, and the interfoliar grooves, they correspond actually to cerebral sulci. And so here we can see on the left upper panel, you can see a early fetus, a 14-week fetus, and the lateral hemisphere of the cerebellum is totally smooth. It's not yet foliated. And at 20 weeks gestation, we can see some early foliation of the cerebellar cortex, similar to what we saw in the cerebral cortex with sulci. In the lower left-hand panel, you can see the same thing happening with the formation of folia in the vermis, fourth ventricle at the bottom of the slide here. And in a mature brain, this is a 14-year-old girl, you can see the normal foliation of the cerebellar cortex. In some cerebellar hypoplasias and Andy Walker malformation and some other cerebellar dysteneses, the foliation may be delayed or even stopped altogether so that the folium and the interfolial grooves never form in some of those conditions. Usually they do, but they're delayed in development. Now here is a neonate with a very thin hypoplastic appearing superior temporal gyrus. Here's the sylvian fissure on the right. You can see it, and you can see on the other side as well. The superior temporal gyrus looks very thin. And this is any neuropathologist or neuroradiologist who would see this would immediately give you the diagnosis of this patient because it's really, there's only one condition that causes this particular appearance, and that is Down syndrome, trisomy 21. And it's often said that the superior temporal gyrus is hypoplastic in Down syndrome. But what we demonstrated with coronal sections of brain of an infant, not this infant, but a different baby with Down syndrome, is that the superior temporal gyrus, if you look here by the asterisk, actually is normal in size. But what's abnormal is that the superior temporal sulcus, which divides the superior and middle temporal gyri, is excessively deep, so that the superior temporal gyrus becomes sort of buried deeper within the brain. And when you look at it on the surface, it looks like it's small, but actually it's not small. And so that's sort of an optical illusion that you should be aware of. And in some cases, perhaps it is hypoplastic, but the cases I've seen, I'll demonstrate that it's really just, it's the sulcus that's abnormal and not the gyrus. Now, I'd like to show you a few examples of some cerebral malformations in which the telencephalic flexure and lateral cerebral fissure, sylvian fissure, fail to form or are formed abnormally. And these diagnoses can be made prenatally by fetal ultrasound or magnetic resonance imaging, and certainly can be done in the postnatal period. Now, in some animals, I mentioned rodents earlier, the rodents, like mice and rats and also rabbits, do not develop a telencephalic flexure. And so their telencephalon looks like the early primitive telencephalon just after the prosencephalon has been divided by the interhemispheric fissure. And if you do electrophysiological studies of a rat brain, for example, and identify the function of different areas, where's the visual area? It's not at the posterior pole, because that's really corresponds to the temporal tip, even in the rat, but it just hasn't bent over. The visual area is in the dorsal part, and that's where we would have expected it to be. Here's a patient with severe microencephaly and a lack of telencephalic flexure. This is a mid-gestation 20-week fetus, and this is a dorsal view of the brain. The brain was very small in size. It weighed only 2.3 grams, whereas normal was about 50 grams for this age. And the telencephalic flexure has totally failed to form. Here's a control at the same gestational age to show you the difference in these brains. This is a mid-gestational fetus with alobar holoprosencephaly. Here is a ventral view of the brain. Here you can see the basis pontis. And here's a dorsal view. And you can see that there's, I hope you can see this arrow that I'm using, but there's a band of tissue that goes across here. That band of tissue is the hippocampus. It's fused in the midline, and it is dorsal in position instead of being ventral, because the telencephalic flexure has not formed. So the hippocampus remains dorsal, and it's continuous across the midline, and it ends at the posterior poles. The visual evoked potentials recorded are recorded at the middle of the prosencephalon. Here's an MRI of a 4-month-old boy with alobar holoprosencephaly. And you can notice that in the two bottom views, you can see in the posterior part of the hemispheres, you can see that there are hippocampi, but the hippocampi are dorsal in position. They're not ventricle. They're not ventral because they have not rotated, so-called rotated, to a more ventral position. And you always have this large so-called dorsal cyst in holoprosencephaly. And the reason this large cyst of cerebrospinal fluid forms is because these fetuses have fetal hydrocephalus, because they have obliteration of the third ventricle and aqueductal atresia. And so there is no CSF flow, and they develop a fetal hydrocephalus. And you can see this in the neonate as well, and in older infants. And it's not often given as much attention as it should, I think, in evaluating holoprosencephaly, that these babies have hydrocephalus as well. It's an obstructive hydrocephalus. Now, this is a drawing that is really not realistic because it's showing you the route of migration, so-called, of the hippocampus from dorsal to ventral position. But it's superimposed on a normal ventricular system of a mature brain, an adult brain. So it's not entirely realistic, but it illustrates why I think you can see this better than if we had put the ventricles of the fetal brain here. And here's the hippocampus in the more ventral position. Here are two cases of lysencephaly type 1. This is a Miller-Dieker syndrome, and both of these children, who are similar age, one was a 6-year-old boy and the other was an 8-year-old, they both have the same genetic mutation of LIS1 microdeletion of the 17p13.3 locus. And so they have identical genetic mutations. And yet, in the brain at the top, you can see that the Sylvian fissure is well formed, even though the brain is largely lysencephalic. It's smooth, as you see here, maybe a little bit of pachygyria in the temporal lobes, but mostly it's lysencephalic. The other brain, B, labeled B, on the right, is also lysencephalic, but look at the Sylvian fissures. They are very poorly formed, just very shallow opercula compared with this one. And yet both of these children of similar age have the same genetic defect. And so you can't always predict from the morphology, from the appearance, exactly what the genetic defect is, because why one would form Sylvian fissures and the other not, I'm not sure. I don't think anybody knows, but it's interesting with the same genetic defect. And here again, a dorsal view of the brain before cutting of this very shallow Sylvian fissure that's in an abnormal position and everything that you can see here. Here's a lysencephaly type 2. This is a case of a 6-year-old boy with Fukuyama muscular dystrophy. It's always associated with lysencephaly and pachygyria that you can see. This is a section stained with hematoxylin and eosin. The ventricles are large. But what I want to show you here is that the sylvian fissure is very poorly formed at the level of the hippocampus and thalamus here, and is very abnormal in this lysencephaly. This is a case that was sent to me many years ago from the Tokyo Women's Medical College. Some colleagues in that institution, Dr. Kaiko Shishikura was the neuropathologist, and Makiko Osawa was head of pediatric neurology at that medical school. Here's a different patient. This is a hemimegalencephaly, and the reason I show you that, well, you can see the shift of the occipital lobes across the midline and the straightening of the frontal horn. But look at the opercula. Here you have a very abnormal operculum on the left side, the hemimegalencephalic side, and the you don't see it as well, but the operculum is normally, the sylvian fissure is normally formed on the other side. This child, a two-month-old boy, was born at term, and he has an L1 CAM mutation, which causes X-linked recessive congenital hydrocephalus with aqueductal stenosis, and he has generalized polymicrogyria. There are no normal gyri in this brain. There are too small gyri. They also become fused on the lateral surface because of a defect in the pia mater and there's fusion of the molecular zones of the adjacent gyri, microgyri, and you can see in the cut section that there was fetal hydrocephalus. But what I want to show you here is the sylvian fissure. It may be a little bit distorted from the hydrocephalus in terms of its position, but it is formed. And so even in this severe case of hydrocephalus, a genetically determined hydrocephalus with generalized polymicrogyria, the sylvian fissure in this case is formed. Here's a 3-year-old boy with bilateral, left more than right, schizencephaly. And you can see that the operculum is widely open, and it's open on both sides, more on the left. You can see that in all of these views. And whenever you have schizencephaly, the cortex in the depth of the fissure is always polymicrogyric. There are a number of causes of schizencephaly, including vascular insufficiency in that area, but it also can be genetic. This child also had partial agenesis of the septum pellucidum, which you see in many cases of schizencephaly, and he had optic nerve hypoplasia. Well, no, they were normal in this case, and there were no endocrinopathies. So we could not make a diagnosis of septo-optic pituitary dysplasia in this case because the optic nerves and the endocrine function of the anterior pituitary were normal, but he does have open and the term open and closed forms of schizencephaly probably is not so important, really. It's something that's very obvious on imaging, and so it's been used a lot in describing the MRI of children with schizencephaly and neuropathologically as well. But these are maturational stages, and probably there's not a great deal of difference in terms of pathogenesis between the open and closed forms of schizencephaly. Now, fetal hydrocephalus, we can ask, does severe obstructive hydrocephalus developing early in gestation impair the telencephalic flexure or other fissures? And we already saw that in one case that it did not. So here are two twin 20-week fetuses with fetal hydrocephalus, both of them due to aqueductal stenosis. The telencephalic flexure is formed, and the opercula are rather shallow, but they are present. And the hippocampi that you can see in the lower right, for example, are in the ventral position, as they should be. And the parieto-occipital fissure also was well formed medially. Here's another case of more severe fetal hydrocephalus in a fetus at 22 weeks gestation who had aqueductal stenosis and massive fetal hydrocephalus with a very thin cerebral mantle. But the effect on the telencephalic fissure flexure was mild, and the insula is shallow, but it is formed. You can see it here, in the lateral view on this brain. So in conclusion, we can summarize this by saying that fissures form earlier than do sulci. They are often deeper and separate cortical lobes. Fissures may result from external mechanical forces, whereas sulci are from internal mechanical forces. And both fissures and sulci are genetically programmed in their sequence of development and where they form. And many cerebral malformations include disorders of formation of the flexures that produce fissures and sulci and gyration of the cortex. So it's important to recognize this in the interpretation of imaging or of neuropathology of fetuses and neonates who have malformations of the brain. Fetal hydrocephalus may delay or distort fissures, but it does not prevent their formation. And that these fissures and many sulci can be detected prenatally by ultrasonography or by MRI. And in concluding, I just want to show you a picture I took in Kananaskis, which is a provincial park of province of Alberta. And this is a mountain in that provincial park. And this mountain has an operculum and an insula, as you can see. I don't have any microscopic views to show you of this, but I think that grossly, I think you can agree that this is these are an operculum and an insula, and so nature has a way of repeating itself in multiple ways.
You see this is a premature mountain?
Well, yes, this may be a fetal mountain. Thank you very much for your attention.
Thank you, Sir Sarnath, for this wonderful talk and for sharing your wealth of knowledge with us. I just see if I go back.
I hope it recorded, okay?
Yeah, I did. I'm just going to stop sharing and see if people have any questions.
Is this live?
Yeah, people are there. So please write your answers or questions in the chat box or in the Q&A. If you have any question, we can. Don't see any questions here.